morning, everyone. Thank you. Thank you so much for coming over and listening to our talk on this early morning. So I'm going to go ahead and start. We're running a little bit tight, so we want to give you so much information, all right? So you can have a healthy brain. I want to welcome other member of the panel with me. Each of them, they're going to introduce themselves when they start giving the talk. We want to thank PeerView and Bright Focus Foundation and Lily who supported this talk. If you haven't done so already, please complete the pre-event survey. That will help tremendously. And then throughout the conversation and then throughout the presentation, there will be polling, a question you can answer through your personal device. You can also send us questions while we're talking, and then we'll be able to answer them in the Q&A question. And for those who are virtually joining us, you can use the chat feature window to ask any questions. And then if you haven't already scanned the QR code for the gift in the beginning, the gift card, please go ahead and do it when we show you the QR code. We will use the same QR code for question polling and also for redrawing the gift cards in the end. We want to thank facilitator who will help us during the group 10-minute group discussion of the cases. I really appreciate you waking up that early. And again, this is the QR code that is the same QR code you use it for the gift card drawing, and the same QR code you're going to use it for polling question. And if you use it a lot, your odds of winning the gift card will go up. So, you know, there's a mathematical background. And then if you need more information, including the slide, these are available on peerview.com, Boston 25, and there's additional resources for you. So today we're going to cover three things. Number one, we're going to try to tell you that Alzheimer's disease pathology starts decades before the clinical manifestation, and that gives a window of opportunity to intervene and change the trajectory of this disease. We're going to share with you recent advances in blood-based biomarker that make the early diagnoses a little bit more scalable. And then finally, we're going to talk about the one of the major breakthrough in brain care, which is amyloid-lowering therapy, and their role in changing the trajectory of specific population. So I'm going to start with setting the stage for you all. I don't know if you don't know this, but if you don't know this, I don't know where you've been living, but Alzheimer's disease is a major issue, all right? Almost 7 million people in the United States have Alzheimer's disease, and that number will double by 2060. And then the current system in the United States across the globe is not set up to take care of the health, really the major breakthrough to help us manage this condition. Number one, there's very, very few people like Dr. Ashton and Dr. Ali. That's number one. There's not enough dementiologists. The infrastructure is not accommodating for early detection in particular, and it's almost like it's too little, too late concepts. And hopefully, we're going to need to work together on redesigning the system to protect our brain, including my brain, just FYI. I'm at very high risk for developing Alzheimer's disease. So I'm doing this personally. I'm very selfish. So the rationale for early Alzheimer's disease detection, in particular in the stage of mild cognitive impairment, it's important. Here's the problem. This is very optimistic. I think this is a little bit 15% of people with mild cognitive impairment are recognized by the system only. I bet it's more like 1% to 5% if you went to the real world. So our system is not picking up people in the early stage of Alzheimer's disease who are at window potentially of changing the trajectory. People want to know the future. At least some people want to know the future. They want to plan for the future. Sometimes a family notices some issue and they don't know if this is age-related or not. So when you actually help them answer that question, even the patient themselves. And now we're going to mention to you that right now there's these two FDA-approved medications that lower Alzheimer's disease. They work if you are in early stages of Alzheimer's disease. If they work, they're going to work in the early stages of Alzheimer's disease. So if you ask American, my enthusiasm about early detection is not unique. Majority of Americans want to know if they have Alzheimer's disease before the symptoms start. Majority of them, large majority, they would like to have a blood-based biomarker test, or at least they will agree with it, and they wanted to take medication that could slow the progression of their disease. And all of them are in the 80% to the 90% from the Alzheimer's Association survey. And these are the three breakthroughs. If you're not aware of them, this is major thing. This is very similar to the 1980s and the 1990s with cancer and coronary artery disease. The big one, which is I'm really excited about for myself, there's 14 lifestyle modification that can reduce the future risk of dementia and cognitive decline by almost 50%, technically 45%. I'm one of those group. I'm working hard to make sure that's my future change. If you're not aware of the last 2 years, we got now 2 FDA-approved medication that will change the trajectory of Alzheimer's disease, but they require early detection. You have to be in the early stages of the disease. And finally, if you didn't know about this, now even if you got very unlucky, unfortunately, and developed dementia, but you want to stay at home, then there's 330 organizations across the United States that are there to help you, support you and your caregiver to optimize the quality of life of both of you and keep you at home with connecting you to resources in the community across your neighborhood. So with that, I'm handed over to Dr. Atri, and we'll go from there. Ali.
Thank you. Thank you, Dr. Boustani. Good morning, everybody. Thank you for joining us this morning. I'm Ali Atri. I'm a cognitive neurologist. I take care of patients and families with Alzheimer's and related disorders. And I've been involved with teaching and research and clinical trials, and particularly even with these maps for about 20 years. And I also spent 18 years here in Boston, and I still have affiliations, and I do some research and teaching here. So it's an exciting time. I can tell you, if I were not to be here tomorrow, and many of us aren't going to be here tomorrow, I think finally the field is at a point where you can't stop the progress. And that's really nice. Be able to say that after all these years of being in the field. I would say it's the end of the beginning. It's still not the beginning of the end. Why do I say that? Because we still have a long way to go. We have a much bigger understanding of Alzheimer's pathology, but I have to be humble. We don't understand everything. We understand things broadly. We define Alzheimer's disease still by a dual proteinopathy, so 2 proteins in the brain that accumulate and become toxic, but there's so many different things that are involved. So as you can see, Alzheimer's, the amyloid species is the first one. And amyloid is like, I think of a toxic kindling that's necessary, but it's not sufficient, right? So there's other things that occur. So as Malaz was saying, 25 years before, when the disease is starting, the soluble forms are starting to come together. And then at some point, you can see they stick together in protofibrils, and then fibrils, they become insoluble. And while that's happening, you notice other things are occurring, neuroinflammation, probably some damage to synapses. And then at some point, we develop a tangle. And tangles are not just in Alzheimer's disease, but they can be in other conditions too. That tangle is almost like a fire that started. And in the presence of having this toxic kindling around, it's like an accelerant, right? And so in between, there's other vascular damage. So amyloid deposits in the blood vessels. And that's one of the reasons we have the side effect of these drugs called ARIA that we'll talk about. And then once the protein machinery breaks down in cells, you don't just have Alzheimer's changes in the brain, you have other proteins that accumulate. Proteins related to Parkinson's disease. So alpha-synuclein doesn't get broken down, TDP-43. So one of the rarest things that occurs in people in their 80s when their brain comes to autopsy is having pure Alzheimer's disease, right? So you usually have multiple different pathological changes. And we probably have to hit them at different stages with different drugs, but we've got a toehold now with these foundational drugs. And the major breakthrough, as Dr. Ashton's going to talk to you about, is the biomarkers, right, which are important. So that's the disease itself, right, the pathophysiology, and then there's a clinical syndrome, right? So imagine that I'm depositing amyloid in my brain right now. It's uncertain. For populations, we know the risk is higher. For a given person, we don't know if you have the disease in your brain, when you may have symptoms. Now, as your biomarkers progress, we know with greater likelihood what's going to happen. But one of the things that the association did is change the definition. And the definition became purely biological, different from the symptoms, saying that you can have Alzheimer's disease without having symptoms, okay? Just like you can have lung cancer without coughing up blood and being short of breath. You can actually look at a scan, be suspicious, do a biopsy, and say this is lung cancer, right? Now, the way they defined the different stages, they said if you have the biology, and we'll talk about that in a second, then you can be in different stages. And you notice that stage MCI and Alzheimer's dementia. So the dementia part and the MCI part, still that requires clinical judgment. So basically one morning you don't wake up and say, oh gosh, I think yesterday I had subjective cognitive decline where, my scores were generally pretty good, they weren't, and today I've got MCI. Because objectively, not do I have symptoms, but on sensitive tests, we can say that I'm scoring less than I should. And then the next week, you don't wake up and say, I think today I have dementia. Because, today, I'm essentially not independent anymore from some complex activity they're living. And that's the line between MCI and dementia. It's a clinical judgment that now you've become dependent on a activity of daily living, okay? So it's a continuum. But you notice that stage 3 and stage 4 are the stages of these newer drugs, the foundational drugs that we have now. They're first-generation drugs. We want to even do better over time. But that's where it's important. That's when we need to, as Malaz was saying, we miss people in the MCI stages. Now, Nick is going to talk a lot more about biomarkers, but many people have seen these they call Jack curves or something like it. So in the x-axis, what you can tell is it's basically the x-axis, shows you the clinical progression, and then the y-axis shows you abnormalities in the biomarkers. And you notice way to the right side is when people have symptoms, okay? And any given person can show their symptoms at a given level of pathology in the brain differently. Why? Because of this concept of cognitive reserve, how people either can be resistant or resilient to pathology in the brain. What we want to do is to increase everyone's cognitive reserve. More education, more exercise, mitigate cerebrovascular risk, a whole bunch of other things. But you notice these curves, they don't, even though we can measure things like neurofibrillary tangles, the neurodegeneration part, or amyloid and tau, they tell us different things. So an amyloid PET that is showing you basically fibrillar amyloid becomes usually a little bit abnormal later than the fluid biomarkers. So spinal fluid, those things come usually, changes on average will be seen first and then on the imaging. Okay, I think we're going to take a second here. And then we're going to roll right through. So please do that little scanning thing. And it's just a little polling question. All right. So, so basically what the association did last year was say, you know what, we can have a framework. We can define the disease biologically. And how can you do that? Well, through CSF, plasma, or imaging biomarkers. And it's sufficient to have one of those core 1 biomarkers. See that first couple of rows? If you have one of those core 1 biomarkers, that's sufficient to say you have the disease. Just like I think you were talking about coronary artery disease, you can have coronary artery disease but not have heart failure, right? We don't know who's going to have the heart failure and when exactly. So that's kind of defining that you actually have the disease. Now, the core 2 biomarkers are still advancing, and this whole framework called the ATN framework is still advancing from research into clinic. And literally every month there's something new that is putting its foot into clinic, right? Now, those core 2 biomarkers, they tell you much more about staging and prognosis. So I can have my amyloid be positive, okay, but not have any symptoms. But once I start getting tangles on that tau PET, the likelihood that I'm going to have symptoms within a few years is very high, okay? So the issue is that tau PET, even though it's approved, it's not generally available and paid for very much right now. It's a first-generation tracer. The others are mostly in research, and you can see that there are other markers, amyloid, tau, neurodegeneration, inflammation, vascular changes, alpha-synuclein, they're all developing over time. So all of them are not ready for prime time. Now, just to let you know that it took us 7 years to do this, but in the US, we've not had a framework for guidelines at every setting: primary care, specialty care, subspecialty care. And this was a multidisciplinary group. We went through an Institute of Medicine review, 10,000 papers, PCOTs. The idea was, can we foundationally put down what should go into an evaluation at each setting, put in the biomarkers, so health systems will give people the resources and payers will pay for them, okay, if it's done appropriately. So, and we had representation. There are a few geriatricians, internal medicine folks in here, ethicists, et cetera. So very, very quickly, what happened is that it was 7 cores, and the cores are wrapped around patient-centered care. And then it's a structured review of systems, doing your MOCA or MMSC, tiers of testing. When should you refer for neuropsychology? Should you do imaging? What kind of imaging and at what level? But it's to answer 3 questions. Is something wrong? So what level? 2, what's wrong? What's the syndrome? Is it memory and executive function, or is it judgment and something else, right? Because your approach still matters for those things. And then what's causing it, what's contributing to it. So what we did is basically come up with 19 recommendations, everything from neuropsychology, what should be done in subspecialty care, when do you use FDG PET, when do you do CSF, et cetera, et cetera. We put it in this flow. And always on the right side, when the answer is no, you counsel people and you increase healthy brain behaviors, okay? Always. That's always a good thing for people. But then as you go down the flow, these are all available free for download. So if you go, there's a special issue of Alzheimer's and dementia. It tells you what are the first tier labs, when do you, if you're not confident enough, when to send for a referral. We have the specialty setting, subspecialty setting, and for the most part, things like amyloid PET, tau PET, some of the CSF, DAT scans, synuclein testing, those are still in the subspecialty domain. They require proficiency, they require interpretation, so you should probably do it in conjunction with people who are subspecialists. So these are the tiered levels of testing. So after you've done, let's say, your structured review, you've done your validated instrument, whether it's the MOCA, the MMSC, Minicog, whatever it is, you want to do your first tier labs. And you can see the first tier labs are screened for common conditions that affect cognition. And you can see them up there. And what you notice, for example, is that RPR is not on there. So you in primary care, you can add things in conditionally if you think there's a clinical context, but not to do a shotgun. And then there's the specialized tests that are reserved, again, for subspecialists, and they become more and more rare. And then we had the emerging biomarkers like the plasma and things like that that are still emerging, and you'll hear more about it from Dr. Ashton. Before I turn it over, I just want to say a couple of other things. Imagine that you're watching TV at night and you see a lot of drug ads, right? And they don't come in and say, "Oh, you have breast cancer, take this drug." Right? What do they say? If you have ER positive, HER2 negative, node positive breast cancer, and you've been on this drug and this drug, then adding this on could have a lot of impact. That's precision. We're going towards that. We're not quite there yet, right? But the reason they've been able to do that is that they've used biomarkers to see which group has the maximum effect, and then also their safety profile. right? But if 20 years ago they had taken that same drug and given it to a population, it may have been negative, or it may have had a very small effect size, right? And over time, they've been able to figure out which folks benefit more. And I think this is the issue, is that we want to be able to go towards precision, and I think that will happen over the next few decades. But it also requires, for now, also to detect people at the early stages. Not to just give them drugs, but actually so they're empowered to make decisions for themselves, for the autonomy's sake. They can decide to do whatever they want, but that's the important part. I'll turn it over to Nick.
Thank you, Dr. Atri. Good morning, everyone. It's a pleasure to be here. I think I have a slightly different perspective when it comes to blood biomarkers, which I'm very proud of, is that I'm a researcher, so standing here talking about these blood biomarkers in patients is quite a big deal. It's been something we've been working for 15 years. So what I'm going to discuss is basically what can these blood tests do, what they can't do. I'm going to try and limit it to the population we're testing them in right now, but I'll make a few comments about where we are with research and what we look at in research as well. So we are measuring phosphorylated tau in blood, which is a biomarker we've been measuring for many years in cerebral spinal fluid. Cerebral spinal fluid is a bit of a dirty word in the US, I know that. In Europe, people give it up willingly. They're coming with their own buckets and saying, fill it up. I want to give someone a perspective. We talk about these blood tests almost kind of passively now, like this. These levels of this protein are femtomolar levels in the blood. This is a trillionth of a gram that we're measuring at these blood tests. And now, in the last 10 years, we've been using quite specialist pieces of instrumentation to do it. But the tests we have approved today are on our workhorse hospital instrumentations that we measure IgG and creatinine on. Now you can measure a trillionth of a gram biomarker test for Alzheimer's disease. So we should just keep in mind the technological revelation that's had to happen here alongside the definition of Alzheimer's disease and the drugs and amyloid PET alongside that. It's really quite incredible. So we need blood biomarker tests. The whole idea around the blood tests when we set out this path 15 years ago was really a triage tool for clinicians to understand very quickly, is Alzheimer's disease pathology at play here or not? Now we have these blood tests, we can answer a lot more questions, but that was the number one, that was the primary role here. So alongside of this, with these FDA approvals of or amyloid-lowering therapies, we have a quick and relatively easy biomarker to say, is it there or not there? I don't think we should be using these blood tests to say how much, or are you going to progress? Right now, they're approved to say, is it there or not there? Of course, we can all understand that blood biomarker testing is really the only way to do this at scale. Maybe that at scale and demand is not here right now, but it's likely to be there in the future. And particularly if we start to go earlier and earlier in disease, our population testing group becomes larger and larger, and the blood biomarker test is the only way to really do this at scale. And I would also argue to get an answer quicker than we would do with a PET scan or maybe even a cerebral spinal fluid test. So of course they're less invasive, they're more accessible. In theory they're less expensive, but we don't have that cost yet from CMS. They're not currently reimbursed. There are ways around it, but the official line is that they're not reimbursed, so we don't really know what that cost is yet. But you can obviously imagine it's substantially cheaper than an amyloid PET scan. It's more acceptable than CSF testing, Sweden aside, and it will give us more access to these treatments. So there are some barriers to blood biomarker testing. We've talked about reimbursement. The knowledge gap, I think, is a huge one here. And I don't think it's necessarily a knowledge gap, it's just we're just moving at a remarkable pace with these blood biomarkers. That the information in the public domain isn't necessarily the correct information. Suddenly we have an FDA-approved blood test, but where's that information in a peer-reviewed journal? It's not there. So if you want to go away and do some independent research and you start going on PubMed and reading about blood biomarkers, I really ask you to be due diligent about what tests they used in that research study. Because the test, if it was a research study in 2022, 2023, these are not the blood tests that are accurate today. That's how quickly this field is moving forward. We did a study with the Alzheimer's Association, which we we published last year and asked all vendors and all research groups that had a blood biomarker of phosphorylated tau to be involved. Many people did be involved, but what that showed us is that there were 35 different versions of this blood test available in research or poised to be on market through different companies, not just the one or two that we have FDA approved. So it shows you that there is a potential confusing milestone ahead when you have so many tests. Which one do I choose? Which one is accurate? Which one will pay us reimburse? So this is an area where we need to be very, very clear in our communication. I think we're getting there with the Alzheimer's Association with these guidelines that we recommend these tests, and that's where we're getting now. And the FDA cleared tests, of course, make that a lot easier as well. So this is the GSA survey in 2024. So keep this in mind. This was before the FDA approval of a blood test. So this is prior to even that. Quite a large number have already used a blood biomarker in their own. So around about a quarter or a little bit more have been using blood biomarkers in their own practice. Remember, you don't have to have an FDA-cleared blood test to use it clinically. You can have a laboratory-developed test. So people have been using these blood biomarkers for a few years now to inform their own clinical decisions in practice. And a remarkable 94% of people said that they would use a blood biomarker test in the future. So that clearly shows us that not only is there a demand from patients wanting to know whether they are at risk for Alzheimer's disease, that also clinicians and people that see the patients also see the value there. So this is where research and clinical use start to get a little bit murky. So our FDA-approved blood tests are only appropriately used in people that are under investigation for mild cognitive impairment or Alzheimer's disease. So the blood test should not precede the clinical evaluation. It should always be the clinical evaluation and then the blood test added as what is the biomarker evidence for that cognitive decline. So that's what they are FDA cleared to do. Now I can tell you from a research perspective that these blood tests work very, very well in pre-symptomatic disease. Dr. Atri mentioned phase 1 and phase 2 where you have biomarker evidence but no cognitive symptoms. These blood biomarkers work remarkably well there as well. So you can see them an avenue in the future for where they have a placement in that area of disease. But right now, they should be coupled and only should be interpreted in combination with the clinical evaluation. So what we should really think about these is that this is just a way of whatever we know about amyloid PET, whatever we know about CSF, we should be able to now get the same information. Regional deposition of amyloid aside from PET, we should be able to get the same information. Of course, that means that they improve our diagnosis of MCI and Alzheimer's disease because you now have an idea of amyloid and tau in the brain. Another thing to add really is that what does this blood test mean when it comes to all these stages of pathology that the Alzheimer's Association has set out? So our blood test, although we're measuring phosphorylated tau, is FDA approved for amyloid positivity. Okay, bit confusing, but that's what it's FDA approved. So does it mean tau tangles? Yes, it probably also does mean tau tangles, but that's not currently what we use it for. And I think the evidence to say it does a positive blood test mean also tau tangles is still in the research phase. So it tells you that there's amyloid pathology there. We shouldn't make any inferences right now about how much tau is there based on the blood test. It's all about is amyloid present. So we have another QR code, which is a polling question. So I'll give you a few seconds for that. Great, we'll move on. So how do we interpret these biomarkers? So we'll go on about what the results actually look like, how they would be returned to a clinician or a patient. But we have to really take into consideration the prevalence of the population here that we are testing. If someone comes in with cognitive decline in specialist care, the likelihood of that being Alzheimer's disease, of course, is much higher if someone goes into to local PCP also with complaints. So the prevalence, and therefore the positive predictive value and negative predictive value of a biomarker really needs to be take into context of your population. Of course, if we ever move towards a preclinical biomarker testing, our prevalence there is even going to be even less. So the negative predictive value and positive predictive value are such important metrics rather than accuracies and area under the curves and that we will see in our research papers. Those accuracies are always really, really good, but they never take into account the prevalence of the population. So this is very, very important to also consider when you're reading these research populations. I would say that in our research populations, of course, the prevalence of Alzheimer's disease is always much higher than we would do in real life, because people are enriched for family history, maybe genetic risks. So therefore, a biomarker could maybe overly inflated look better in research populations because the prevalence is higher. So, complicated slide, but this is the recommendations now for our use. You can use a blood biomarker as a triage test, or what is good enough for a triage test, and what is good for a confirmatory test. So, just want to point you down here for the sensitivity and specificity. So these are taking into context the prevalence of different age populations. So we can use the biomarker as a triage test, which means we would need a confirmation from CSF or PET afterwards to confirm that. Or we could also use it as a confirmatory test. So 90% specificity, sensitivity. I would say that those metrics are a little bit arbitrary at the moment. I would like them to probably be a little bit higher. So that's not taken from any other areas of medicine. That's just a guideline and an agreement from the association. But there are many of these blood tests that reach those metrics, but some that do not. So we have to take into consideration this. We also have split up by primary care providers, so where the prevalence is going to be a lot lower, and also by a triaging test and a confirmatory test with dementia specialists. This is how we are interpreting the test. Most people are doing this. Of course, if you have a laboratory-developed test, each individual lab comes up with their own cutoffs and their own use criteria, but now we have an FDA-cleared versions of this test. This is how we would look at it. Again, the person that you're doing the biomarker test or the blood test in is someone that has cognitive complaints. Maybe not cognitive impairment, I think that maybe that's incorrect, but cognitive complaints. They've come into a clinic or they've reached out because they are concerned for their health. The blood biomarker would put you into 3 distinct categories. One, which is in the positive group, this would be confirmation that amyloid pathology is present. The lower cutoff, which rules out amyloid pathology, remembering that these individuals have cognitive complaints, so it doesn't end the diagnostic question there. It just kind of rules out that Alzheimer's disease pathology is the cause of that decline, pushes that individual into maybe a different evaluation. But very, very important that we have this intermediate zone, and this is a bit of a tricky area now. We have a blood test, it's not 100% accurate. So we have about 15 to 20% of individuals that are intermediate. Now, what would I say about this intermediate zone? I would say that they're also intermediate on PET and CSF. I think this is a true reflection of the state that they are pathologically. So we just have very, very clear defined cutoffs with amyloid PET, whether you're positive or negative. You can see the amyloid in the brain. It's very clear for us to do. So our recommendation, if an individual falls in that area and that they have cognitive impairment, is that these individuals go for a more specialist test. So these are people that would have amyloid PET in the US or CSF in Europe. So this is how we're using these tests. The guideline of 20% in the intermediate zone, again, is just a guideline where the association would like to see. So 1 in 5 of individuals that have a biomarker test would fall there. 80% of the people that we see, in theory, but based on our margin, could be resolved with the blood test, at least in combination with the cognitive symptoms. Okay. Another area which is very important to distinguish between what is research and what is meaningful for clinical practice. Blood tests, like phosphorylated tau and 181, like any blood test, let me just mention, in clinical chemistry, are affected by the comorbidities that person has. This is not unique to phosphorylated tau. This is, you can see where I'm passionate about here. If you have some of these indications, particularly chronic kidney disease, that's the one you will see mostly written about. If you have chronic kidney disease, the blood biomarker levels of phosphorylated tau will be higher. They will change the concentration of that biomarker. Now, let me just state what is most important in clinical practice. Does that person change category falsely? And that answer is no. So the person will not go from negative to positive because they have chronic kidney disease. So that's a very important metric to have. This is easily resolved because creatinine levels are generally going to be available. So if you're concerned that the creatinine levels are too high, then the blood biomarker maybe isn't appropriate. You should order a PET scan. So I don't think we should be over-interpreting these comorbidities in relation, because it affects every protein that's in the periphery. But the data is out there. You will read this a lot, that chronic kidney disease affects phosphorylated tau. And it is true at the concentration level, but not true when you're deciding whether someone's in those three distinct categories: negative, intermediate, or positive. Now, there is a lot of information and a lot of different biomarker tests, as I've mentioned before. This is a great tool, but from the Alzheimer's Association, where you can plug in the biomarker test of interest, you can test the prevalence, how accurate is that blood test with a positive predictive value, negative predictive value, that's appropriate for your clinic or appropriate for your research. As I mentioned, there's over 20 different versions of these tests. Some are really good, some are not so good. I wouldn't say they're bad, but they're not so good, and this is very, very important. This is our FDA-cleared blood test, or our first one, on the Lumipulse by Fujio Bio. Again, you can see that we have defined cutoffs, and we have the prevalence estimates of how well this biomarker works in a population that is in specialist care. So this test is recommended for people over 50 years of age in a specialized setting, and you can see that the positive predictive value is 90% and the negative predictive value is 97%. So the positive predictive value of that test is lower than the negative predictive value. So although it's a little bit higher than what I've said before in our estimates, I still think that we should be a little bit cautious here, that a positive predictive value or positive test should still be confirmed by a specialist test. But the negative predictive value of this test is very, very good, and maybe that could be that biomarker end there. Again, you can see that you have an intermediate zone, and with this test, about 20% of the participants end up in that zone in this population. We have a second blood test that was approved very, very recently on the Roche platform. This is looking at phosphorylated tau 181, so a very similar biomarker to 217. And this is approved as a ruled-out biomarker. So again, it has a very high negative predictive value. You can see from the statistics on this screen here that the positive predictive value is even lower with this test. So again, it's a rule-out biomarker. Anything other than that needs to be confirmed with a more specialized type test. But now we have two FDA-cleared blood tests that we can use in clinic. So to conclude, blood biomarkers are extremely accurate for identifying Alzheimer's pathology. I would refine this a little bit and say that it's accurate for identifying amyloid pathology. Remember, you can have amyloid pathology and not being Alzheimer's disease. And so if you think about preclinical disease and people that have incidental amyloid, these blood tests will come back positive. So our interpretation of these blood tests need to be put into consideration there. It cannot confirm AD dementia. That needs to be in line with the cognitive assessment. It's a supportive tool to say that the pathology is there. And I think we do have some ethical considerations for blood biomarkers, particularly as we think about the future, when we go into, or if we go into asymptomatic decline. Who gets access to the results? Who will demand these results in the future? How do we pay for these tests? There's a whole area of ethical considerations. Where we were with genetic testing, I think we're going to be there in the next decade for biomarker testing, something we need to get a handle of. Here's another polling question. I think this is my last slide. Someone wants to nod? Yeah. And I'll hand it back to Dr. Atri.
Great. Thank you, Dr. Ashton. There was a lot of material, and it is very complex and it's very dynamic. But I think that the take-home points that are very consistent with the clinical practice guidelines are that, not test and then work up, it's work up and then potentially test, right? So even, those two tests that are FDA cleared, whether it's a specialty setting or the primary care setting, people had symptoms and they were worked up. And actually, I think the primary care one, with the Roche one, I think in primary care, they got MMSE, quick dementia rating scale, actually, they got the CDR, I believe. They got the CDR, which is, it's quite a level of a workup. So, we're trying to learn how to do these things, and so it is important to know those caveats. All right, so we're going to switch gears and talk a little bit about goals of treatment. I think about multiple sort of pillars of care. The first one I always think about is a timely, accurate, and compassionate a diagnosis and communication of that. I think if you have delayed diagnosis, then you're really denying justice and care to people. So that's one. The second part I think about is psychosocial education and telling people how to use non-pharmacology and about the condition and planning for the future. Then you think about pharmacology, and the first thing I think is not to give a bunch of drugs, is actually simplify their med list, because some of those things may be anticholinergic, and some of the symptoms they've had for many years, maybe actually because of the Alzheimer's changes in the brain, whether it's sleep issues or potential anxiety. And then we think about appropriate use of the medications for people, and then wraparound care for the patient and the family members and the care partners. Really, really important, right? I think you guys know about these medications that we've had for almost, for 20 years or more. They're generic, they're available, and they're important. Let's not forget that these are not mutually exclusive. Just because we're talking about disease-modifying treatments, it doesn't mean the effect size for these drugs are not there. There's 20, 30 years of research that shows that basically these drugs are important. But why is it that it's different from the disease-modifying drugs? Symptomatic drugs help with symptoms, and generally for a group, they'll put people on, for a group, usually with cognition, they'll put the group at a higher trajectory, and then ultimately, as the disease progresses, you get a parallel slope with the untreated group, okay? And if you stop the drug, generally people will fall. And the myths about the drugs, they work for 6 months, they work for some people, that's not true. We've done delayed start studies, randomized withdrawal studies for these things, where even in later stages where the clinicians thought people weren't benefiting, and they randomly took them off, then we saw the group that was taken off, like the Domino AD study, did much worse over a year. Their cognition went worse, their function went worse, their behavior became a lot worse, and they ended up in the nursing home faster. So they're important, and they have their place, but they're different. Again, they're not necessarily working in the pathophysiology, and we haven't actually had biomarkers to know about that. So they may be a little bit, changing the course, but ultimately it's like bronchitis, that's bacterial. You give the inhaler to help with the breathing, but you need the antibiotic for the disease modifying, right? So these are the only FDA approved drugs. There are two other drugs that are FDA approved for special indications. There's brexpiprazole in agitation with Alzheimer's dementia, and there's suvorexant for sleep. Now, we're never going to reach for those two drugs until we do all these other things, including trigger analysis, making sure somebody doesn't have pain or dehydrated or has a UTI, etc. All right, back to our disease-modifying drugs. Why are we making such a big deal that this is a foundational issue, even though they're far from cures, okay? It's important because the properties of disease-modifying drugs, by definition, are two things. They're doing something in the pathobiological pathway of the disease, okay, that's number one. But most importantly, they have to do something clinical. They don't necessarily improve symptoms, but when you look at the slope of decline, they'll change the slope of decline compared to untreated, okay? And so over time, what you'll see is, for at least for while the drugs are in that category, the slope should be changing, right? The slope should be different, and if you stop the drug, you shouldn't immediately have symptoms again, right? So the benefits are more longer lasting. Now, the monoclonals, again, they're first generation, and they're hitting different species of amyloid. So you notice that, for example, there are 3 drugs that are approved. Aducanumab was accelerated approval. It's no longer marketed. Okay? But the 2 that are approved, donanemab and lecanemab, if you think about the evolution of the bricks, you have these think about soluble bricks of toxic A-beta 42. They come together, and they're still soluble, and they make dimers and oligomers and then protofibrils. Lecanemab works more on those protofibrils, right in that soluble becoming insoluble stage. That's where the target is mostly. Does it lower plaques? Yes, by some mechanism. It's also lowering plaques. Donanemab really hits the mature plaques, the pyroglutamate plaques, okay? So it's a little bit different. All right, let's see. All right. The basics, I mentioned how they work. Well, they're the first disease-modifying drugs that we have, but they have to be given at the stage 3 and 4 of AD. What does that mean? It means you have to have biomarker confirmation that you actually have the plaques they have to target. So 20 years ago, when I was involved in these, we were giving it to people that look like they have the syndrome, and we know that about 15 to 20% of people that look like they have Alzheimer's disease actually don't have that. They have TDP-43, vascular, alpha-synuclein, or a combination. So first, you have to confirm they have amyloid positivity. They have to be in the right stage, MCI or mild dementia, okay? And then there's a number of things that I think Malaz is going to go through appropriate use that you have to make sure for safety reasons that you're doing your due diligence. They don't have too much cerebral amyloid angiopathy in the brain. Their blood vessels aren't too leaky, and they don't have other exclusions. But basically what they're doing is they're trying to lower those plaque levels, okay? And can you hold up your hand if you're average in every aspect? You're average? Anybody here? Okay, good. Because what we do in clinical trials, we cherry pick populations, right, to show that something has efficacy and we understand the safety to a point, right? And we show it for populations. We show it for a population. So when you see an effect size, that doesn't mean that's average for those people, for that population. It doesn't tell you whether you responded. Some people respond better than others, right? And on average, about 80% of people given these drugs in the phase 3 trials become amyloid negative by about 18 months. Now, remember, you've accumulated that amyloid over 20, 25 years, and we're making almost everybody, not quite, about 2/3 to 3/4 of people amyloid negative. What about the impact on slowing? Well, on average, not just on the primary endpoints of cognition, but or function, we're seeing it on multiple endpoints: severity of disease, behavior, about 20 to 40%. And I'll show you a series of slides. Number one, to show that they're disease modifying. Are they hitting the target? Remember, something in the disease. Are they lowering plaques? Yes, I'll show you that. And then whether it's lecanemab or donanemab, you'll see no matter what endpoint they look at, there's a difference in slope between the treated group and the untreated group, about 20 to 40%. No, who has had their patients usually come and say, well, what I really want is in about 18 months, compared to placebo, I want my CDR sum of boxes to be about 0.45 to 0.6 different from placebo in 18 months. Is that the goal of treatment for most people? No. Most people, even cognitive neurologists, we don't do CDRs in clinic, right? So what people want is they want to retain their personhood. They do not want to become dependent. They don't want to progress to the next major stage of dementia. So if they have MCI, if they're in the MCI stage where they have symptoms, but they're essentially independent, they don't want to become dependent, go to the dementia stages. And basically, they want more time. They want more time. So in that 18-month period that these clinical trials were there, it saves on average about 5 to 7 months for that period of 18 months. Now, I'll show you some long-term data that suggests that that benefit increases, that time benefit increases over time as you go out 3 years or 4 years, okay? Important to note, these are not cures. Let's not overblow them. They're not going to, on average, change, make somebody undemented, okay? And then they come with risks and burdens that we'll talk about. There's amyloid-related imaging abnormalities that we have to be concerned about, that we can manage, But you know what? It's complex, and it requires specialists, and it requires a lot of communication. There's infusion reactions, and we have to have MRIs and other things to monitor people. All right, this is a very quick tour. I'm not going to go through all this stuff. Please download the slides and look at the stuff. This is number one, showing you that lecanemab and donanemab, guess what? When you give it, on average, they decrease the plaques on the left, and they move CSF amyloid markers in the right direction, on average, okay? So biological effect, check, okay. What about clinical effect? Remember those slopes? Look at the slopes. No matter how you look at it, in each of these major endpoints in the trial, and for lecanemab, it was CDR sum of box on the left, right? You can see the divergence in slopes. So showing that there's efficacy. Now, don't be fooled. People say, oh, well, look, it was 0.45 difference on an 18-point scale. That's nothing. No, that's efficacy. And guess what? Nobody comes in on in an 18 or a 12 or a 0 on this scale. You have to be just right. So the people who come in have CDR sum of boxes about 3 to 4, and you notice the placebo group drops about 1.5, 1.6. So that difference of 0.5 is about a third difference. Okay, that's showing there's efficacy, and then you can see it on the others, whether it's cognition, function, we're not showing behavior here, but even in composites. So it's not just one domain that it's hitting, about 20 to 40%. This is recent data. This cannot be. This is only the first 18 months was randomized, right? So what they did is then they did the open label extension. So the curves on the bottom are highly matched observational groups. But what you notice is in the first 18 months, that observational group that was matched by amyloid status, CDR, all those things, matched perfectly their decline with placebo, right? So after that, the people who got drug kept getting drug, and the other group was added on. What you notice is the benefit doesn't go away, right? So again, the preponderance of evidence, both from the RCTs and the open label, are showing that these drugs look like they're disease modifying, which is very important. This is the donanemab study. Now, for the donanemab study, again, you had to be in the MCI or mild dementia stage. You had to have MRI within a certain amount of time. They also did a tau PET. Now, in clinical care, we don't do tau PETs, and it's not required. But the people who had no tau or very low tau, they didn't include. But everyone else they included in a combined group. There was a low to medium tau, and then in the combined group. What it shows, the biological effect, check on the left and on the right. Now, not everybody is amyloid negative. The other thing that they did was different on the study, was they, after every 6 months, they did amyloid PET scans. And the people who were cleared, unbeknownst to them or the people in the trial, they switched them to placebo, okay, to see if that group was going to be any different. With the drug, if once you stop the drug and you don't have amyloid, does your benefit go away? The answer, it didn't go away. So again, disease modifying. These are the results. No matter how you look at it, the primary endpoint was the IDRIS. It was a combination cognition and function. Whether you look at it that way or the CDR sum of box, whether you look at it in the combined group or the low to medium group, there's benefit. And actually, the benefit is a little bit more, it seems like, group-wise on the people who had less tangles, right? So suggesting both here and in some data from lecanemab that going a little bit earlier is probably better once you're symptomatic. Okay, so that's an important take-home message. And then this was their long-term, same thing. Remember, the first 18 months is randomized. They have a placebo group, and then the placebo group is also matched with this observational group, Atri. And then after that, people are switched over. And again, what you notice is that the benefit doesn't go away. And the thing to notice is that a lot of people are no longer on drug here, right? Because their amyloid's been cleared and they've been switched over to the placebo. Does that make sense? So the benefit hasn't gone away. Is this cure? No. You can see on average you're still declining, right? So we're not giving people that expectation, but we've got a disease-modifying feature. Now, the big worry is ARIA. ARIA is an imaging-related abnormality. It's imaging. It's not a symptom, okay? What does it represent? Fluid shifts. fluid shifts on leaky blood vessels that leak regardless, actually. So people with Alzheimer's disease leak, and I'll show you, they all have, a lot of people have microhemorrhages to begin with, and people who had 5 microhemorrhages or more couldn't come into these studies because their blood vessels are probably a bit too leaky. But so what we're trying to really avoid is serious ARIA, right? So people having seizures or death, which has happened in clinical trials, but it's rare. It's rare. And so basically, people have to report symptoms if they occur. The vast majority of ARIA was captured on surveillance MRIs. 3 out of 4, there was no symptoms at all, okay? But if there were symptoms, they're usually mild. A little vague headache. Maybe I'm a little bit less steady today. Maybe I'm a little bit more confused today. So that's why actually it requires a fair bit of communication with the patient and the care partner, if people are on these drugs, to try to figure out, gosh, is this the headache in their normal life, or could this be ARIA and I need to do an MRI to see if it's there? And if ARIA is there, there's management protocols. You may pause the thing, and it usually goes away within a few months. So you have 2 kinds. You have the hemorrhagic kind, and you have the edema kind. Now, the purpose of the slide, this is very busy, is to show you that whether it's a class effect, whether it's donanemab or lecanemab, you can get ARIA, okay? And the other purpose of it to show is it's related to ApoE4. So how much ARIA you may get is related to having ApoE4. So if you're heterozygous, if you have 1 E4, you have more of a chance than if you were E33. If you're homozygous, you have 2 E4s, you have more of a chance. Now, do you qualify for getting the drugs? Yes. So if you're homozygous, you can still get the drug. But you should be counseled that your likelihood of ARIA or recurrent to ARIA or serious ARIA may be higher, okay? That's one point. The other point is what you'll notice is these rates can change, right? Between, lecanemab and donanemab weren't direct comparisons. But what you'll notice is there's a background ARIA-H even in placebo. Even in placebo. So people on placebo are accumulating microhemorrhages. So that's why we have to be careful about these drugs. Now, the ARIA rate was a bit higher in the phase 3 trials for donanemab, and all they did was they were giving infusions every 4 weeks. So these drugs are infusion drugs, first of all. That's one major point. They're infusion drugs. You either get it every 2 weeks, which is lecanemab, or you get every 4 weeks, which is donanemab. Now, there's a maintenance phase. Just recently, lecanemab has an auto-injector, but later on, not for initiation yet. But what they did is every 4 weeks, as you got 700 milligrams of donanemab for the first 3 doses, and then 1,400 milligrams, they switched the first and third dose. So instead of getting 700, the first dose was 350, then 700, then 1050, and then the 4th infusion was 1,400. Just by doing that, look at the ARIA rates that fell down. Because it turns out ARIA, if it occurs, usually it's in the first 6 months, and it's related to, how much drug exposure you're getting. So you notice they dropped the E4 homozygous ARIA rates from almost 60% to about 20-something%. Okay? Any monoclonal, you guys know, you can get infusion reactions. Okay? Usually they occur there early on, and they're usually mild to moderate, and they usually, if they occur, you just give them some acetaminophen, maybe some diphenhydramine, but you don't need to pre-medicate everybody, and just because you're E4 doesn't mean you have to be on steroids, okay? These are manageable. All right, I'm going to turn it over to Dr. Boustani.
All right, so I'm going to go over kind of closure for all what you heard already from our 2 other speakers. So just to put it together, now we have 6 stages of Alzheimer's disease in particular. The first 2 stages, no symptoms, maybe a subjective symptom in stage 2, but clearly no cognitive symptoms. Stage 3 and 4 are these mild stages where you have mild cognitive impairment, no functional problem, or you have mild syndrome, some functional problem caused by your cognition that impact maybe your instrumental activity daily living. Then the late stage, this is where you have impacting on clear impact of your cognition on your functioning, social functioning, and even move to the severe stage to your basic activity daily living. So in the early stage, lifestyle changes, risk modification, amyloid targeting therapy, and possibly cholinesterase inhibitor. In the second stage, you stop doing amyloid-lowering therapy. You now continue with cholinesterase inhibitor and other medication, but now you are becoming more and more symptomatic, and that's where the GUIDE model, the collaborative dementia care model that available in 330 organization, start helping you out. And late-stage GUIDE continue to keep you in that piece, and you focus a lot on optimizing the care, the quality of life of both the care recipient and the care partner. So I'm going to focus on appropriate use for these amyloid-lowering therapy. The first things, they have to have mild cognitive impairment or mild dementia, and you have to prove that these symptoms are caused by Alzheimer's disease pathology using amyloid-based PET scans or CSF-based PET scan. They have to have making sure you do genotyping for their EPO-E44 because there's a lot of effect modifications on their risk of developing ARIA. You can figure out how can I tell they have mild cognitive impairment and mild dementia in more objective way. If you are using the MMSE, then it's depending on the medication, it's 20 and above. If you are using MoCA, it's 18 and above. And they all need to have an MRI in the past 6 to 12 months to look at their risk for developing what ARIA said. Who are the people who will be excluded? If they can't get an MRI, then you can't give them this because you're not going to be able to do proactive surveillance for and monitor their risk of ARIA. If when you do the MRI showed any evidence of that leakage that Dr. Atri mentioned to you, and very specific criteria for that leakage and the presence of microhemorrhages in particular and macrohemorrhages, the guideline recommend no anticoagulant use. They cannot have a bleeding disorder. They cannot have primarily other medical conditions that require immune therapy treatments. The dosing for both of these medication, I'm going to go over in a little bit in detail. Lecanemab both of them are infusions, both of them up to 18 months. The lecanemab start every 2 weeks. The infusion can take around 60 minutes, one dose, 10 milligram per kilogram, and you give them all the way to 18 months, and then after that, at least for the lecanemab, you can consider giving to them every 4 weeks, or if now with the subcutaneous injection. For donanemab, you give them once a month. It's 30 minutes. And it starts with a titration now, 350 milligram in the first month, 700 second, 1,050 the third, and then you put them on the maintenance. But there you can stop the amyloid lowering therapy starting with 6 months, depending if you want to repeat PET scan and if they have cleared up the amyloid from their brain. And then the monitoring perspective, it's primarily MRI-based monitoring. There's a little bit change between the lecanemab and donanemab, but in a nutshell, you do a lot of surveillance for detecting ARIA in the beginning, in the first 6 months proactively. And any time your patient come over and present with possible symptom while they're taking lecanemab of a headache, gait abnormality, or focal neurological deficit, think about ARIA. It might be the underlying causes or pathology for their symptoms. If you can complete this other question. Now you are star. You can know how to use it. This is cognitive test. Just and then just to remind you, in the mild cognitive impairment stage, there's a lot of other comorbid conditions that might cause mild cognitive impairment. And theoretically, if you take them off, their cognitive function might improve. More specific one, medications, and particularly medication with adverse cognitive anticholinergic effect. So I'm gonna now, we went over the amyloid lowering therapy for the early stages, MCI, MCI due to Alzheimer's disease or mild dementia. And now we're gonna go for the moderate and severe stage, and I'll focus a lot on the guide model because it's really focused on the dyads and using non-pharmacological approach. So if you're not familiar with the guide model, unfortunately it's too late for you, because you have to wait for another 8 years or 7 years to get approved by CMS to be one of these provider. But if you are a patient, or if you have a patient you want to refer, find the guide approved organization that can help you. So what does Guide do? Guide give money to providers in a really good way, especially if they were business savvy, to actually support patients and care partner. It gives money for you as a provider to measure their biopsychosocial need, develop individualized care plan with them, and then try to optimize the quality of life of the patient and the care partner and keep them at home as long as possible by offering them 24/7 access to dementiologists, at least by phone, actually support the care partner and coach them how to cope with the cognitive, functional, psychological disability of their loved one and their own stress level. And the most important thing, it gives each family, give them $2,500 every year. It's not too much, but for certain people, $2,500 is a lot to cover respite services. So with that, I'm going to stop here, and we're going to be moving to actually you guys discuss these cases in front of you. There's 2 cases, and you can discuss them. We'll give you 10 minutes to reflect on these cases, and then we'll come back and reflect all together. All right. Right. So, welcome back, everyone. So, we can go ahead and maybe continue the discussion of the cases. But if anybody want to share their reflection on the case, and come over to the microphone. There's two of them. Oh, three. There's three. So come over to the microphone and maybe share your reflection with us. All right, about case one, we can start, and then maybe case two. So who's the brave person who will come over and reflect?
No volunteers?
Come on.
Remember, there's no, even the guides that we put in there are just general things to stimulate discussion, because
Yeah.
we're all trying to work these.
We're not going to judge you guys. We're not going to judge you. I swear.
I think.
All right, here's one person. Amazing.
Okay, thank you. All right, what you got?
Okay, group one, Gerald is a 55-year-old man with concerns about cognitive symptoms. So the first question that we had was it appropriate for Gerald's PCP to order a p-tau 181 plasma test at this time? And the answer is no.
Good for you.
Yes.
I said I won't judge, but look at the judgment.
That's why I wanted question one, because this is too early for all the other details. But, he didn't meet the biomarker testing is indicated for patients who have objective evidence of cognitive impairment based on the structure, the multi-domain, the diagnostic evaluation, which was not conducted with Gerald. Gerald's performance on the MOCA suggests that he does not have cognitive impairment. His lifestyle is more what needs to be corrected than all these different tests, that blood tests, the biomarkers and all. And I think also we also talked about his depression. And I think his depression has to do with the loss of his mom.
Wow.
Because I think men grieve differently over their mom than women.
Well,
Very good. Thank you so much. That was very good. Thank you.
Okay, so I'll be taking question two. It says, if Gerald's p-tau 181 test result is negative, first question is, how would you interpret his test result? So we came up with, if negative result shows no cognitive impairment, there could be a chance for false negative, although it also shows association with positive amyloid. The second question is, would you recommend any other diagnostic test for AD? No, because his previous test, which is a BBM test, or maybe say the MOCA test, is negative and normal, though we could also recommend further tests due to his age and other associating factors. Then the last question is, would you recommend any lifestyle modifications? Of course, yes. He should reduce alcohol, and he should at least get more physically active. Also, we recommend a healthy heart diet, change in his nutrition. We could refer him to a dietitian and also refer him to a physical therapist due to maybe pain or the physical demands surrounding him. And we could, of course, refer him to a mental counselor for his mental health and also to reduce and relieve his anxiety and also because of his history. So those were
Where do you practice? I'm going to send patient to you. Thank you.
Thank you.
Okay, so if his test came back positive, we can't say for sure that it can be confirmed because it's not diagnostic for amyloid pathology. So we had some recommendations to continue monitoring symptoms, to maybe consider a CFS test or amyloid PET scan. In terms of specialty care, we also thought about something similar to the last group. So assessing anxiety for his concerns about his decline. Lifestyle, I think she mentioned most of the things, but in addition to like the alcohol use, we also thought about insomnia and maybe talking about the list of medications to see if there's any changes that need to be made in his ongoing medications. And then we did not think he'd be eligible for amyloid targeting therapies at this point since he doesn't have mild cognitive impairment or mild dementia due to Alzheimer's.
You act like geriatrician.
Thank you.
Thank you.
So I have a follow-up question here, because we discussed this case here, and I think we all agree that the blood test was inappropriately ordered. And then we discussed here, if it came back negative, we'd all have a sigh of relief because we know what to do with that now. But what if it came back positive? The information is still true, but now you have an inconclusive test. Do you continue to go down the biomarker routing test, or do you revert, say it comes to you, Dr. Atri, to a specialist from the PCP? Do you revert to and explain to them that this was inappropriately ordered, or do you go down the more specialized biomarker route testing?
Yeah, so again, my setting is a little bit different. I'm a subspecialist cognitive neurologist. Even a subspecialist, I specialize in atypical cases and young onset. So for me, usually they've seen 6 different people. They're in their 50s and early 60s. People think they're anxious, depressed, they're drinking too much. Usually a boss changes and they get fired. This is a typical situation. Nobody thinks about Alzheimer's disease. So this person has a history of young onset potentially in their family member. And what I see is he's drinking too much, he's anxious. I don't know if it's hypertension's controlled. So if he were to come to me, I don't go just by that MoCA. No one test, whether it's the p-tau or the MoCA, is going to tell me. I assess the patient themselves. So in my setting, I would do some additional testing, and because I have availability of neuropsychological evaluation, it's not testing, it's an evaluation. So it allows me to get a baseline for him right now. And then what I would do is really work on the drinking, the insomnia, all that kind of stuff, and see how he is after that. It could be the symptoms have gone away. And take it from there and follow him longitudinally. And if it's in primary care, I would say the thing to do is to say, hey, we've got to take care of those things first, right? And see what happens. Now, if he's very adamant that even after that things are, there's symptoms, then we'd have to think about something. Now, I've been in that situation. What we're getting is discordant tests sometimes. So what we're getting right now is sometimes people have given these tests to people and they think they have Alzheimer's disease, and they're coming to us. And we talk about the pros and cons about, okay, you have symptoms, you have this test, what are our options, right? Remember, clinical trials are also an option for someone like this. If once they're clean, once they're drinking and all that stuff, they can go into a preventative trial. And what would happen in the preventative trial, as you mentioned? They get the p-tau test first. If it's positive, what happens? They get a confirmatory test. Yeah. So then they get the amyloid PET scan or the CSF. So I think what I would do is to have a very patient-centered discussion with him and family members, et cetera, about that, about what that means. And I would look at the sensitivity and specificity of that test. So some of the tests, as you know, are highly sensitive, but they're not specific. So one of the recent ones has a sensitivity, I think a specificity of like 53%. And so a positive predictive value of only 22%. So one has to explain those things to patients. There's no formula for me, I would say.
Yeah.
Well, I think for us as in the geriatrics, mental health specialty, we have something. So let's imagine, this has happened, by the way, in the real world. So let's imagine this person was not supposed to get biomarker, but they came over, they did the biomarker, it was positive. So for us in geriatric mental health, at least in our place, we have something you don't have. We have time, all right? So we actually bring them over, and we have a family conversation, and we use the new Alzheimer's disease staging. This is really, really good for this. So technically, they are potentially in stage 1 or 2. In this case, it's stage 2 if the person said, I have cognitive thinking. So it's not just worry, I think my thinking has a problem, okay? So then they become subjective, all right? Then the question become for us, because the MoCA was 30 out of 30, do they really have subjective? They have cognitive. We have neuropsych testing, like Dr. Atri said. I look and see if they perform in any of their cognitive domain below 9 percentile. So if they don't, then they are technically then, it's stage 1 and stage 2. Currently, stage 1, stage 2, there's no amyloid lowering therapy. There's something much, much better than amyloid lowering therapy, which is what? Lifestyle modification. In lifestyle modification, we take it very, very lightly, cool, because we love writing a drug. Do you know why we love writing drug? Because it's so easy. It's very easy and very precise, all right? Where lifestyle changes require me to modify your physical and social and digital environment. A great example, how hard it is for me to make you guys all stand up and running right now in this environment. It's very hard. You're gonna fall, correct? If you start running over here. So we have a system that is not set up for lifestyle modification change. But for us in the center, we have coaches who can help with you, and we can work with you and say, look, most likely you are in stage 2, maybe stage 1. We can reduce your risk by 50% if you do the following. We keep very, very focused on your blood pressure, making sure below 130. We make sure you don't take any anticholinergic. We manage your stress and your anxiety. You optimize it. You clean you up from the alcohol. And we work with you on the 150 minutes of moderate exercise every week, you know, without like driving you crazy. We put you on the mind diet, you know, and we help work with you on do cognitive exercise on top of your physical exercise. That's 45% risk reduction. Doesn't even come close to the amyloid lowering therapy, but you're not skills, you don't have the time to work on this. Do you know who has that time? Concierge medicine. I'm just telling you, that's what they do, all right? They can have you a coach, and people who are executive. The people who come over and see me, they are very high executive, some of them, and they have coaches for their mental health, and they have coaches for their physical health, you know, and they have chef and all these kind of things. That's the goal. You can do 45% reduction, all right?
Case 2, I guess?
Yes, sir. Oh, yes, ma'am. Sorry.
I think we're just going to do case 2.
Case
All
2,
right.
lovely, thank you.
So our group answered that first question of how do you interpret Leslie's test results, and we said positive biomarker test, so she's likely to have amyloid pathology, hippocampal atrophy. She was ApoE positive. She's a heterozygote. Her MMSE showed she had mild impairment. Now our case said she didn't have any ADL or instrumental ADL impairment, but we respectfully disagree with that because she can't drive anymore. So we thought that was a bit of an IADL, but that was what we saw. So that's question 1.
Good. Thank you. Positive reinforcement, guys.
So quickly touching on questions 2 and 3, given the time, so additional testing. Our group thought that we didn't have enough information about cardiovascular risk, so additional labs, kidney function, blood sugar, hypertension, so on and so forth. We didn't have that information. And given the positive blood biomarker, PET or CSF would be warranted. And in terms of care plan, I thought the group did a really good job in thinking about just before conceptualizing the whole care plan, we need to have open, transparent discussions of, before we even start prescribing all of this, what are the implications, what's the follow-up going to be, and we were very impressed that this patient is either in New York or Boston because they were able to get to a specialist that quick, and that's not what happens in the country in general. So we need to think about location and how that's going to impact everything we do for this patients, but I think that's what the team discussed.
Thank you so much. So we're running out of time. It's 8 o'clock. So what should we do, guys?
Take some questions, or we can discuss some of these, I think.
We can stay. I'll stay here if you have any question. All right.
Okay.
You
Yeah,
wanna
whoever wants to stay, we'll stay on for a few minutes, do some Q&A. I'll give you a quick anecdote, actually, which is it's not an act, it's true. So kind of what Nick was asking me about. So I had a patient, actually, somebody that I went to school with, and the father is a bit older, but very, very, very bright lawyer. And They noticed some memory changes, and he went and saw somebody, basically got a p-tau 181, it was positive, got an amyloid PET scan, it was read as positive, and at that point, they ended up having a lot of turmoil in the family because his wife was saying, you have Alzheimer's disease, I need to now take over things. It got so bad that it blew up. By the time he came to see me, his wife had moved out of state because he was very adamant that, look, I have some changes in my memory, but I really don't think I have Alzheimer's disease. I saw him. He did have some memory changes, and we did neuropsych because he's so bright, you have to do neuropsych. And, by the time somebody like him who was scoring in the 90s, still scoring like on the 95th, 98th percentile on most tests, if his test score for memory is 25th percentile or 18th percentile, it may not hit the 8 or 9% threshold, but really it corroborates some of the things. Anyhow, we discussed about the fact that, okay, I need to see the scan myself. He gave me the report on his phone that said his amyloid test was positive. I said to him, look, you've got 2 tests that are positive. With this syndrome, it's almost 98, 99%, but there's always a chance that that's not the case. And 15% of times like this, it could be TDP-43 or something else in other cases. We discussed doing a test. He went for the CSF test, okay? Meanwhile, the PET scan came, the images finally came to me. I opened it up and I started looking at it. It was stone cold negative. The PET scan was stone cold negative. And I brought the fellow in, and the fellow looked at it, and I said, what do you think about the scan? I didn't tell him. He goes, this is a negative scan. I said, well, that's Mr. So-and-so's scan. We even looked, and it said the centiloid read was -3. So centiloid is a quantitative read, and people should know that the level should be 30 or higher. What is my point? My point is that you can even have errors in reading tests. So the first one was a false. So what do you think his CSF showed? Negative. CSF was negative. He does not have Alzheimer's disease, right? And so these are the reasons. Like in real life, it's not like the textbook, and it's not even like Nick was saying in publications. So, amyloid PET was the reference, the gold standard was pathology. And when you had 8 experienced readers, they were pretty concordant and their accuracy was high, 95% or whatever, about that level. In real life, we have our readers are nowhere near that. So this is why for you guys, you're actually now the specialists. You really are. And so when there's discordance, we have to treat the patient. And so that's really, I think that's my take-home point there on this anecdote, which is absolutely true.
Well, I have a question for Nick. Do blood-based biomarker replace the need for a PET scan, or is a PET scan still needed after positive blood test, assuming the patient have mild cognitive impairment? So let's assume they are in the stage, stage 3 or stage 4.
So, from my perspective, then we can get a clinical perspective. Yes, I think so. And it also really does matter on what type of test you have. So we have 2 different types of tests that we described today. One was the 181 test, which Dr. Atri just described here. That shouldn't be read as positive. I think it should be read as not negative. I know that's a bit confusing, but that would always need to be confirmed of an amyloid PET. The other one, with the FDA-approved test, which is this Lumipulse test, which is in case 2, is a little bit better on the positive predictive value, but still, I think, insufficient for us to really say that this is positive, particularly when that route is amyloid-lowering therapies. So if that is the route, then I think it needs to be confirmed by an amyloid PET scan.
I got you. Another question, maybe Ali, you're more involved in maybe in policy. Do you think Medicare will cover the blood-based biomarker testing now?
I think they will.
Sufficient amount of money?
Well, I think they'll cover it. I think it makes sense, but again, it has to be done under appropriate use. It has to be done in a workup, so it shouldn't be done in isolation. So again, I don't have any stock in any of those companies or anything like that, but I think it's a step forward. It's just a question, like it's a tool like anything else. And we have to know the nuances of it and how to wield that tool.
Oh, thank you so much. So I think we're running out of time.
One more question.
Oh, one more question. All right.
So I do treat people, and I always confirm with an amyloid PET. But Dr. Ali Raza, I think, already answered it, that there's so much discordance because I've had p-taus 1.4, 1.7 to 17, and then an amyloid PET that's negative. That has happened. I've had CSF that has been positive. The ratio has been positive. And 1 year later, I'm getting a p-tau 217, and that's negative. Now, what do I tell the patient? So, of course, I have to get an amyloid PET then, because I have a discordance between the CSF, which was very positive, and a blood test that was that's now negative, a p-tau, and now I have to get an amyloid PET, so 3 different tests. The patient is confused too. But I'm just wondering about these p-tau 217s that we get very frequently. If they're positive and the amyloid PET is negative, is it some kind of tauopathy? You know, is it possible there's some other? I mean, I've seen NPH with p-tau 270s often positive, with you know, but can it be just some other kind of tauopathy?
I would make the comment that, and Dr. Atri alluded to it, is that a fluid measure of pathology can often be positive before the PET scan. That's what we've shown in research before. So I think the centiloid value is very, very useful here, because at the moment you're getting a positive or negative, but that centiloid value was around 18, 19, 20. I would expect to see the blood test to look positive there. So I think that the quantitative measurement of these scans are going to become more and more important, because I think that discordance between fluid and imaging can be explained. Sometimes it's just a complete mismatch, right? So, but I think that discordance can be explained. So they are quite complementary in a sense. I'm not sure if you want to comment.
Yeah, and again, the most important part is, does a person have symptoms, and can you objectively confirm that? That's really, really important, because, you know, in the case where you've given the test and it comes back negative, well, you still have to think about, gosh, okay, well, if I've done the workup and I've given this to the right person, well, I have to explain their symptoms somehow, right? So that requires a workup. If it's positive, then you put it in that context and say, does everything hang together or not? And again, that's why it comes down to the patient themselves, what are the goals are, how much do they want to know, what are their goals of treatment. So, and I'm part of that appropriate use recommendation group, independent group, with many of us have 20 years of experience with these drugs. And right now, you know, where the appropriate use say, you know, you need that confirmatory test with amyloid PET or CSF. Now, we're going to redo it, and in certain settings, you know, maybe that's enough to have a very, very good test in a certain setting. But we're not quite there yet. At least we haven't updated those criteria.
All right. Thank you, everyone.
Thank you very much. Appreciate it.